Okay, right. My name's Laura Fraser, and I run the second line sickle screening laboratory at Central Middlesex Hospital. So, uh, this slide just shows some of the crucial elements involved in a screening program. Obviously, informed consent, and in this case, it's the consent of the parents. Timing's also important. It has to be done at such a time that it will be benefit to the patient, so that intervention can be implemented for reduced morbidity and mortality. In the case of sickle, the sample is taken with all the other newborn screening tests at day 5 as the heel prick sample on the newborn blood spot card. Transport should be easy, and in this case, because it's a blood spot card, it's very easy to transport the samples. The laboratory techniques for testing should be robust, and so that there can be a significant, so that there aren't significant incidences of false positives and false negative results. And in the case of sickle screening, these are fairly minimal. Lastly, for a screening program to work, the results need to be efficiently and effectively communicated. Sickle screening can be done at many different times. In this case, what we're talking about is in the newborn period, and the samples are taken at 5 days old. You can also screen during the school years, antenatal screening, which we do here as well, preconceptual screening, prior to anaesthetics, and presentation with symptoms. What are the aims of newborn screening? The most important aspect is that individuals are detected early enough to get maximum benefit from treatment. Also, so it can be cascaded to other members of the family in case they need to be made aware and would benefit from testing. We want to particularly target at-risk families and to allow better resource planning. Another important thing to remember is that screening is not diagnosis. This means that not every haemoglobinopathy state will be picked up on screening. For instance, not all types of carriers will be picked up. However, when I say this, it doesn't mean to say that when we give a result for a sickle cell disease, that this isn't the case. This will be the case, that it is a sickle cell disease. It's just that not every aspect of diagnosis can be achieved. Universal newborn sickle screening was implemented in England in 2003. As I said before, the samples are taken onto newborn blood spot cards, and they're done at the same time as all the chemistry newborn screening tests are done. So the national screening programme really dictate what can be done and when, and they also dictate what methods can be used for newborn screening. So for first-line screening, the methods have to be either mass spectrometry, HBRC, which is high-performance liquid chromatography, or capillary electrophoresis. The second-line screening can be one of any of the above, but also includes isoelectric focusing, which is a type of gel electrophoresis. Now, there are certain requirements that laboratories have to fulfill to perform newborn sickle screening. Not just any laboratory can provide this service. Across England, there are 13 newborn sickle screening labs, and each of these labs are specifically commissioned by NHS England to provide the service. They have to be UCAS accredited, which is the United Kingdom accreditation service, whereby labs are inspected on site every 2 years. And in fact, we were inspected last week, so I'm exhausted from that, but it went very well. We have to participate in a national quality control scheme and also meet certain other criteria, such as turnaround times and reporting back key performance indicators to the commissioners. So at Central Middlesex, we provide the second line screening for 4 first line laboratories, which are those detailed on the slide: Great Ormond Street, St Helier, Addenbrooke's at Cambridge and Portsmouth. And annually we receive about 5,000 samples. So the National Screening Programme states all the conditions that must be detected through screening, and this is a list of them. So it basically includes all the sickle cell diseases. And originally the programme was set up specifically just for sickle cell conditions, as there's clear evidence that early intervention is beneficial. However, the techniques that are involved also pick up the beta thalassemia syndromes. So these are also reported back to clinicians. Besides the carrier states as well, there are also so-called clinically benign conditions which are detected. These are reported out as well to healthcare professionals, who then provide counselling, and these particular babies are treated according to local policies. Okay, as I stated earlier, a screening programme is not a diagnostic service, but also there are certain things that can't be picked up in newborn screening. And these states listed are really specific to newborn screening because of the haemoglobins present in newborns. Newborn babies have a very high amount of fetal haemoglobin, which then decreases during the first 6 months of life. But because of this high amount of haemoglobin F, these states listed can't be detected in the newborn, or can't be diagnosed. Now, this slide is just an overview of the testing part of the screening pathway. The first line labs test cards by their method, and any abnormal results are sent by courier to us for confirmatory screening. We then send back the cards and the results to the first line laboratories, where they enter all the results onto the child health computer. We also send out abnormal results to the various sickle cell centres that we deal with around London, depending on where the child lives. Any affected or disease state results are entered onto an internet-based database called the Newborn Outcome Solution. This database automatically notifies the appropriate sickle cell centre that there's a new affected baby, and that's done by email to a generic email of the particular sickle cell centre. Right, and one of the few interferences for sickle cell screening is the transfusion of red cells. This means that the haemoglobin that we're testing does not belong to the patient, but it's from the transfused red cells. Often premature babies will receive a blood transfusion in hospital, so there are recommendations from the national programme for these particular babies, and that is that the ideal situation is that a heel prick sample is taken on the day the baby's born and then kept aside to affix to the normal day 5 blood spot card. So, i.e., a pre-transfusion card is taken at day 0 and then attached to the normal blood card, which is sent for thyroid and PKU, etc. That's presuming that baby hasn't had an intrauterine transfusion. sometimes this ideal situation doesn't happen, of course, and in this instance, on receipt of a black spot card at the first line lab, which states yes to the question of transfusion, or if the sample states no, but here at Central Middlesex, we have a high index of suspicion regarding a transfusion, then a sample can be sent to King's for DNA testing on the white cells. This isn't ideal, so it's better to have a pre-transfusion card, because when they do the DNA testing on the white cells, they're only testing for the sickle gene. So they don't receive the full screening, if you like. They just specifically test for the hemoglobin S allele. So they can only tell whether there's a homozygous SS or hemoglobin S with something else, and that something else might be hemoglobin A, i.e. it's just a normal sickle cell carrier, or it might be hemoglobin C, in which case it would be a hemoglobin SC disease. Now, at the first line laboratory, there are certain triggers for them to send the card for secondary or confirmatory testing. Obviously, if there's an result, they will send the card to us. When there's no hemoglobin A present, they send the card, or when it states there's a family history of a haemoglobinopathy, either from the mother or the father, and most especially when both mother and father are carriers, and that's deemed an at-risk baby, and whether the result at the first line screening is normal or not, they will send the card to us for double checking. Right, so I'll just briefly go through some of the methods that are employed for screening. And a relatively new method, which has been put into routine use in the last 5 years, is mass spectrometry. Now, this method is mutation specific, and initially it was thought that it could be introduced to eliminate the second line confirmatory screening, because there should be no false positives in any way, because the kit specifically looks for the mutation of the clinically significant hemoglobins. However, as yet, this has not turned out to be the case, because some labs, so for some first line laboratories, it's been relatively easy to introduce mass spectrometry, because a lot of these labs that do all the other screening, chemistry screening, they already have a mass spectrometer to do this screening. Now, these analyzers are very expensive, so the initial outlay is a lot of money. But if they've already got the analyzer, it's relatively cheap for them to add the kit to look for the sickle screening, sickle and other clinically significant hemoglobins. But for some of the labs, they didn't have mass spectrometry analyzers, and they did their first line testing through other methods, so they are fairly resistant to changing. So not all labs do their first line screening by mass spectrometry. Also, because it's such a new methodology, the screening program were a bit nervous just to introduce it without any confirmatory testing. So even labs that do their first line test by mass spectrometry they all still send for second line screening, and that will probably continue for quite a while. So what happens is that they use a kit, and it specifically looks for the mutations for the clinically significant hemoglobins, and it expresses the results as a number. It's a ratio. And once the ratio goes above certain published action values, then that's deemed as abnormal, and the card will be sent for second line testing. So this is an example of the results from mass spectrometry. So you don't really need to pay too much attention to this, but we need to know, even though we don't use mass spectrometry at Central Middlesex, when we get results from Great Ormond Street, for instance, which is our biggest first line laboratory, they do test by mass spectrometry, and they will send us their results as well as what they think the baby is. But we need to be able to interpret the mass spectrometry results as well, so that we can double check what they're saying. So basically the columns just reflect the ratio for each of the clinically significant hemoglobins, and anything that's slightly above a cutoff indicates that that result is abnormal. If it's just slightly above the cutoff, it indicates that that might be a carrier for that particular hemoglobin. If the ratio is grossly over the cutoff line, then that indicates that the baby's probably homozygous for the particular hemoglobin. And these are just the published cutoff values for the clinically significant hemoglobins. Okay, another method used is high performance liquid chromatography, or HPLC, and this is our preferred method at Central Middlesex, and the one we mostly use to confirm samples from Great Ormond Street, certainly who do the mass spectrometry. So when we confirm what the first line laboratories have got, we have to do that by one of the agreed methodologies, but by a different methodology than the first line lab. So for people that, when they've done the mass spectrometry, our go-to method for second line screening is HPLC. And it's an automated method which basically utilizes the fact that different hemoglobins have different charges. So they stick to a column, and then buffers put through the column, and it, if you like, it knocks the hemoglobins off, the different hemoglobins at different times, and the results are presented as a chromatogram, which I'll show you in a minute. That's just a picture of the analyzer, not very exciting. Another method that we use at Central Middlesex is a type of gel electrophoresis, and again, it's based on the different hemoglobins have different charges, but this is a completely manual method, and it is takes quite a lot of skill and attention to detail to master doing it and to master interpreting it. In the UK, this is only used in second line screening because it separates the hemoglobins, but it doesn't quantitate them. So can't get any amounts of the different hemoglobins. We just separate them into what they are. And that's just a picture to show you the gel. All those little bands represent different hemoglobins, and all the test patients are placed near to control samples, and we basically measure the baby's variant result and compare it to a control result. Okay, the last method that the National Screening Programme allowed to be used for newborn screening is capillary electrophoresis. This is an automated method, and again, it's similar to the HPLC in that it produces a chromatogram. It's just a slightly different method of getting it, but it's again based on the different charges and hemoglobins. And this is an example of the chromatogram. We don't do capillary electrophoresis at Central Middlesex, but again, one of our first line screening laboratories does, so we have to be able to interpret it as well. And basically you just get peaks, which are shown here on the chromatogram, which represent different hemoglobins. So usually in newborn screening, the peak which is shaded in black is the biggest peak, and that's the fetal hemoglobin. And in this chromatogram, there's two other peaks. One of them's hemoglobin A and one of them's hemoglobin S. And it labels it as hemoglobin S because it knows, it thinks it knows at what point it should come on the chromatogram, and so it labels it as hemoglobin S. That doesn't necessarily mean it is hemoglobin S. That's why you need a second test to confirm. Okay, so I'll just go through some example results that we might get to look at. So the chromatogram at the top is the sort of result that we get from our HPLC analyzer. And on the y-axis, you have a relative amount of the hemoglobin, and on the x-axis is the time. So if you look along the baseline from left to right, at the beginning, you get small little blips. These are different adducts of hemoglobin, like glycosylated hemoglobin and acetylated hemoglobin. But then you get to the main big peak, and in newborn screening, the main peak is the fetal hemoglobin. And the table on the top is how the software of the HPLC analyzer, depending on the time that the hemoglobin takes to elute from the column, it will designate it what it thinks it is. So number 5 has taken a certain amount of time to elute from the column, and it's designated it as hemoglobin F. So it doesn't definitively mean it is hemoglobin F, but that is the time hemoglobin F takes to elute from the column. So again, that's why you need a second check to confirm that that is hemoglobin F. Anyway, but it will be. This is a normal baby, and the main peak is hemoglobin F. And then as you go further along from left to right, there's a second main peak, which it's designated as hemoglobin A, which is consistent with a normal newborn baby. Below is what we would see on our isoelectric focusing gel. Again, there's a certain amount of skill to interpreting the gel, but at the top we have slightly blurred on this because I've had to enlarge it. It's not so blurred on the actual gel, but as you go from left to right, there's a very faint little band, which is the hemoglobin A2. This is in the top one, in the control ASD control, which is, we have to make up controls. ASD wouldn't normally be possible to be present in a normal patient, so we make this up. So as you go from left to right, you can see a very faint band, which is hemoglobin A2. And then as you go along, the first band is hemoglobin S. And right next to that, and these two do separate, is hemoglobin D. They're slightly more blurred, as I say, because I've had to enlarge it. And then you keep going along towards the right, then the darkest band there is hemoglobin A. Sorry, I've moved on to the next slide. So, sorry, I moved on to a sickle carrier. This is the normal, back to the normal trace. It still applies. So the top one is a control sample as well, and going from left to right, the first band you see, there's two bands together. The first band you see is hemoglobin C. Next to that's hemoglobin E, and then this dark band is hemoglobin A. So underneath that, that says 41 plus 3, that's the gestation of the baby. And you can see from left to right, two main dark bands. The first one from left to right is hemoglobin F, and then the second one's hemoglobin A. After that are just different adducts of hemoglobin. Those are the two important bands, and that is just a normal result. There's sort of equal amounts of hemoglobin F to A because it's because this is a term baby. The one underneath is the more common one to see. The very dark band is hemoglobin F, and then as you go more to the right, there's a faint band which is hemoglobin A. So lots of F and a little bit of A. Okay, so now this one that I got on to talking about. So on the chromatogram, we can see that left to right, the first band you come to with a really big peak is the fetal hemoglobin, hemoglobin F. Then next, you've got another peak, which it's called hemoglobin A. And then after that comes hemoglobin S. So the HBLC has called it hemoglobin S because it's come in the window of time that it knows hemoglobin S should elute at. So when we check our chromatograms, we have to check that the variant hemoglobin has come in the correct window of time. So that's all part of our checking process and quality control. And then if equally, we match that if we do isoelectric focusing as well. So the top one is a control where we've got hemoglobins S, D, and A. And the one with the arrow, as you go from left to right, the first faint peak is the hemoglobin S. Then the very dark peak is the fetal hemoglobin. And then to the right of that, there's a faint peak, which is the hemoglobin A. And then another dark peak, but that's the cetylated hemoglobin. So we're interested that it does have hemoglobin A, which is the faint peak in between those two darker peaks. And then we would also measure the hemoglobin S peak from the A and make sure that it's the same as the control. And that is enough to say that that baby is a sickle cell carrier. Well, in fact, we would only do one of the tests. We'd probably, depending on what the first line laboratory did, so we would probably only do the HPLC. For sickle cell carriers, you definitely need to do HPLC because you need to quantitate the amounts of hemoglobin A and hemoglobin S to make sure that there's more hemoglobin A there than hemoglobin S. Because if there isn't, if there's more hemoglobin, sickle hemoglobin than hemoglobin A, that could potentially be a sickle beta plus thalassemia. So we need to be very careful that it conforms to a normal sickle cell carrier pattern. Okay, and so it goes on in a similar way. So this chromatogram has a big peak, which is hemoglobin F, and then moving to the right, there's another one, which is A, and then the third peak doesn't come off the column till much later, and that's where hemoglobin C comes off, and it's put it into the hemoglobin C window. And on our gel as well, the top sample is a control. So as you go from left to right, the first band that you see is where hemoglobin C runs, and the second band, which is quite near to it, is hemoglobin E. But the patient sample underneath, if you can see that the first band that you come to is in line with the C. So that's a C carrier. And these are just examples of the other clinically significant haemoglobins. So this is a trace for an E carrier. We've got mostly F, then hemoglobin A, and then a smaller amount of hemoglobin E, which is quite consistent with hemoglobin E because of the thalassaemic properties, so you don't get as much hemoglobin E. And on the IEF also. Now this is an example here where our main peak is hemoglobin F, and then to the right of that is hemoglobin A, and then to the right of that on the chromatogram is another peak, but it's put it into the hemoglobin E window. So this is where you have to be particularly careful because, as I said before, just because it's put it into the window doesn't mean to say it is that hemoglobin. So in this case, when we put it on the gel electrophoresis, above we've got an ASD control and below we've got an ACE control, and our patient sample, the variant where the arrow's pointing is not running with the E, it's running in a similar position to the D. So this is an example of just because the HbRc puts something in it in the window that thinks it's hemoglobin E or whatever hemoglobin doesn't necessarily mean it's that hemoglobin. And in this case, this patient is a hemoglobin D Iran. So not one of the ones that we need to bother about in newborn sickle screening, but just to show that not everything is as it seems. Now, this one is an actual hemoglobin D carrier, but this has put it into the D window on HPLC, and this is a hemoglobin D Punjab carrier, which we would be concerned with. Okay, this chromatogram shows the main peak, which is hemoglobin F, but in the A position on the table, there isn't any peak at all. And then in the S window, there's a small peak. And equally on the IEF, from left to right, where the arrows are, you get one peak in the S position, then a really dark peak in the F position, and then as you go further to the right, in between the F and the acetylated F, there's no band at all because there's no hemoglobin A, and this is just hemoglobin, fetal hemoglobin and sickle hemoglobin. So it's a sickle cell disease patient, FS. So at this stage at newborn, we can't tell whether this, whether the genotype is SS, S beta 0, or S hereditary persistence of fetal hemoglobin. So, but this would be referred onto the newborn outcome solution as an affected baby. Now here on our chromatogram, our big main peak is hemoglobin F, and then in the A position we don't have a peak at all. The next peak we have is in the S window, and then right at the end we have another little peak which is in the C window. So this baby is an FSC baby, again, which would be put on the newborn outcome. Oh, my gel has disappeared on this one, but this one is a trace from a full-term baby, and you can see there's only one main peak on the HPLC trace. So this is just hemoglobin F only, and in a full-term baby, this would most likely be a beta thalassemia major. So we would also put this on the newborn outcome. Sometimes, if the baby's very preterm, you can't really detect much hemoglobin A,
but on a full-term baby, this would be an abnormal result. And so they would definitely be some sort of beta thalassemia major. Okay, so just some of the problems encountered during newborn screening is that we always have to be mindful that the baby might have been transfused. Often the midwife, whoever might have just ticked the no to transfusion, even though, or they might not know that the baby's been transfused. So we always have to keep in mind that the patterns of hemoglobin are consistent with the gestation of the baby. Also, as I said, with premature babies, sometimes it's very difficult to detect hemoglobin A. However, with our methods, we can usually, I don't think there's hardly any ever in our 30 years of screening that we haven't been able to detect even the tiniest amount of hemoglobin A in premature babies. We also have to be careful that we watch for older babies, because that can give a pattern of hemoglobin, different hemoglobins that look as if there's too much hemoglobin A, and so you might wonder whether the baby's been transfused. But equally, the newborn screening program will accept babies that have moved in from abroad up to 1 year of age, so we always note the date of birth of the baby as well. Certain other weird variants can not interfere with the result, but we just have to be mindful to that we only report the clinically significant hemoglobins, but sometimes they don't really interfere with the result, but you just have to be careful of what you're looking at. And again, conflicts between the child's result and the parental results. When we send our results out to sickle cell centres, when affected babies, they always check the parental results before going to visit the baby and check that they are consistent. And lastly, any conflicting results between the first and second line testing. This rarely happens. If it does happen, it's usually because there's some other weird variant there, but at all times we have to make sure that our results are in line with the first line testing lab, and if they're not, we repeat all the tests and get a second spot from the first line screening laboratory just to make sure that they're consistent. Okay, the sort of reports that we generate from Central Middlesex are affected baby reports, and as I mentioned before, for FS babies, that's babies that only have fetal and sickle hemoglobin, we can't differentiate between SS, S beta naught thalassemia, and S hereditary, I've missed the S, and hereditary persistence. That needs to go for either genetic testing or testing later on. But they are all referred onto the newborn outcome system. Also, we generate carrier reports, which we send to sickle cell centres by generic email, and they go for counselling for the families, and other benign conditions, they go for counselling and local procedures. Okay, last couple of slides. This is just to show how many affected babies we get at Central Middlesex. Last year we got 99 potentially affected babies. We have the highest number of diseased babies in the country here, and most of them came from Great Ormond Street Hospital. And this is just a breakdown of the types of affected babies that we get. So the great majority are FS babies and FSC babies. Just to note that
hemoglobin FE, so fetal hemoglobin and E hemoglobin at newborn screening, this could be either homozygous hemoglobin E, which is generally clinically quite benign, or hemoglobin E beta naught thalassemia, can't be distinguished by screening in the newborn state. So any babies that have hemoglobin, just hemoglobin F and hemoglobin E, are reported onto the newborn outcome system, and then they're either parental results looked at or they're tested again later. So out of these 11 that we had at Central Middlesex, there was just 3 that were hemoglobin E beta naught thalassemias. That's it. Thank you. Just after 5.
Thank you, Laura, and thank you for condensing that into the shorter time frame caused by the technical issues at the start. I was just going to ask, are you able to hang on for any questions that might be from the audience? So I realize we're running over, but does anyone have any questions they would like to ask? Maureen.
Hi, it's Maureen Scarlett in Luton. Hi. Finally, I get to see you. We've chatted for so many years. Just a quick question. We get, I had 2 recently where the screening result from yourself has then gone back as, well, the initial screening has come back on the blood spot saying, was it code 07, that it's not normal. But then we never seem to get the sort of final result. Is that a gosh error that they don't send it back to us, or, you know, it's not uploaded?
Is that from Child Health, do you mean?
Yeah.
Yeah, that's Great Ormond Street. They should be uploading everything onto Child Health, and yeah. So the code 07 can mean a few things, can't it? So,
well, this one I literally had today was a D Punjab Beta Thal, but we've never seemed to have got the final result. We just get the code 07 on the initial with all the blood spot results, but then we never get to that final result, and then the parents get issued a sort of normal letter.
Oh no, well that shouldn't be happening. So if that's coming from Child Health, then there's something going wrong there. Code 07 result, because of all the things it can be, that we will send a report of that though to the sickle cell centre, like you're talking about in Luton. That will go to Brent, actually.
No, yeah, it's a bit of an anomaly. No, the Luton ones will go into Brent. But when I look at the record, we don't seem to have the sort of final.
So if you're looking in Child Health, then that is Great Ormond Street. You need to ask them what's happened there.
Right. Okay.
Yeah. Yeah, unfortunately we have nothing to do with the Child Health. So all the results that Great Ormond Street send to us, we then send back to them with those codes, the 07, 04, blah blah, and they're supposed to upload everything onto Child Health.
Yeah, you just had the sickle cell not suspected, other disorder requires follow-up, but then we just didn't seem to get the last bit of what it actually was.
No, I see. I know what you mean. They should be uploading that. So yeah, I'd ask them what's happened. Give them an example. Yeah.
Yeah. Okay. Thank you.
That's all right.
Thank you, Laura. Thank you, Maureen. Does anyone have any other questions for Laura?
Yeah, sorry, I'm going to be. I've got her now, so I've got 20 questions. With the ones that have had a transfusion, and you say they go off to King's, and they just test it on the white cells. Does somebody then, or who generates a request for a repeat sample at, say, 4 months of age, or is it expected that somebody will make note of it to retest this baby?
Yes, again, so yes, so of the ones that come back negative from King's, i.e. there's no sickle present, they get sent, the results get sent back to Great Ormond Street, and they should issue a report saying that it's negative, but saying that that means it's unscreened for the other hemoglobin, you know, like C, etc., CD. So there should be, so again, I'm not really privy to how that goes out, but there should be something on it alerting whoever gets that they should test the baby again, 4 months after the transfusion for the screening. So again, that's something to sort of follow up with Great Ormond Street. We don't see them because anything that's positive at King's, so i.e. 1 sickle allele or 2 sickle alleles, we get the report for that, and then we action that appropriately. But all ones that are negative go to Great Ormond Street for sending on in the appropriate way.
Yeah, no, I was just thinking the ones that, especially the sort of prem, obviously they're usually prem babies, but if they get the you know, they've had a transfusion or whatever and they get missed, who then requests further testing at, say, 4 months, or, you know, post 4 months post transfusion.
Yes.
For the rest of the because obviously they'll get a letter with all the other blood spot bits on, but then they would need a repeat test. And it was who would do that request.
Yes. Well, again, I'm not sure about that. That might be something that you might need to find out from I don't know, the screening program or
so I have a meeting tomorrow, so I'm getting all.
Yes. Bring that up, because we only get the abnormals. Bring that up though to find out. I'm not sure who's responsible for retesting.
Okay.
That hasn't helped very much either, has it?
Well, it's not. It's in as much as it's not you. Yes.
Yeah. Not me.
Okay. Thanks, guys.